Hello and welcome to another episode of Hema Now, our hematology podcast series. I'm your host, Dr. Jonathan Sackier, and in this series I have the honor of speaking with some of the most impactful and forward-thinking experts in the world of hematology. Today I'm delighted to welcome the Editor-in-Chief of EMJ's Hematology Journal, Professor Emanuele Angelucci. The good professor is Director of Hematology and Cellular Therapeutics, and of the Stem Cell Transplant and Cellular Therapies program at the Istituto di Ricovero e Cura a Carattere, Scientifico, Ospedale, Policlinico, San Martino in Genoa. My apologies for my pronunciation. He also serves as head of the Department of Oncology and Hematology, a position he's held for the past 11 years. After earning his medical degree from the University of Bologna, he completed fellowship training in general hematology, clinical oncology, and internal medicine at the University of Ancona. Since then, Professor Angelucci has devoted his career to advancing care for patients with hematologic malignancies and haemoglobinopathies. It's a great pleasure to welcome Professor Emanuele Angelucci to the podcast. So, welcome, Professor Emanuele Angelucci. Lovely to have you here.
Thank you. Well, thank you to anyone is listening this presentation.
Well, I'm sure many people will be. And well, let's start with a few quick fire questions just so that we can ease into this. And I guess I've been involved in medicine from the days before stem cell transplantation. In fact, did work on stem cells in the 1980s. And I've been fascinated to see where we are. So putting you on the spot, can you summarize the future of stem cell transplantation? It's easy for me to say, in one sentence. What was one sentence?
Oh, the future transplantation has grown so much in the last decade and continue to give us opportunity to cure malignant and not malignant disease. The future is to have this procedure available for much more patients that are available now to further decrease mortality, increase disease eradication possibility, and most important, to make this technology available for many patients, particularly for those living in low-income countries who now cannot have benefit from this procedure.
Yeah, well, we're going to dig into all these things. That was very eloquently stated, Emanuele. It's perfect. So you've been involved in this field and have contributed for over 3 decades. What inspires and drives your passion for the use of transplantation in the field of hematology?
Oh, this is a very difficult question because there are a lot of issues to remember, and I have to go so much back to the beginning of my professional career. And what was fascinating was since the beginning, as was the possibility to cure malignant disease, which were considered uncurable at the time, and what was really impressive, the continuous improvement during the decade. You can consider that when I started this profession as transplanter, we consider a hold for this procedure patient over 35 years old, 35. Now we transplant patient even 70, 75 years old. This is an incredible improvement during the year. We solved a lot of problem with infectious disease, problem of toxicity. Now in an experience center, transplant-related mortality is less than 10%. At the beginning was so much higher. Now we have still a big effort to do it with eradication of malignant disease. But the improvement has been so much during this year. Another example is that in the beginning, with the only donor was an HLA identical sibling. Now we have a pro-transplant. We have much unrelated donor transplant with more than 40 million volunteer donors worldwide. So there was really fascinating, the continuous improvement in this field and the possibility to cure repeat, to cure many patients.
Yeah, absolutely. And I have friends who've been treated for a variety of conditions. In fact, a very dear friend was one of the first women to receive BMT for her breast cancer. Question, I'm astounded, 40 million. For in every other field of transplantation, a shortage of donors is the rate limiting factor, right, for kidneys, livers, lungs, hearts. What are you doing that you get so many people to volunteer? Is it because it doesn't involve a major operation, or is it?
No, okay, this is it's an important field. To be a hematopoietic cell donor doesn't make any mutilation to the donor. This is different from kidney, from heart, from liver. That's of course it is a procedure, and sometimes it's a surgical procedure with bone marrow aspiration, but this is a very not invasive surgery. And now we have the possibility to harvest hematopoietic stem cells for peripheral blood. This is make the donor much more safer, even if risk is not zero as in any medical procedure, but it's very limited and considered an ethical procedure, making it donor safe in almost 99.99% of the cases. This is really important. Then moreover, to be in the registry, just need your HLA typing and to be your data in the database. Then the probability you are called is around 1/1000.
Yeah. Well, I'm just wondering if I've been a blood donor for many years, and I don't think I've ever been asked if I would be willing to be a hematopoietic stem cell donor. It's interesting.
What
I,
what's the question?
I have donated blood
Ah,
3 months for many years, but I don't think anyone has ever said to me, would you be prepared to be a hematopoietic stem cell donor?
oh, I don't know in your specific case, but usually uh, this is not easy to explain because HLA typing is not AB0 typing. It's much more complex, and there are people in the world who are no donors. So, with the actual number of volunteer donor, we cover almost 65% of the Caucasian population because this is a limitation of the hematopoietic cell volunteer donors. This for so far is mostly for Caucasian people, and what you say? Oh, sorry. Uh, and that's now it is very unlikely that increasing the number of the donor we can reach more patient. That's the politics is in this phase is to have young people. So you are in no hold, but usually for this kind of transplant, the young people is preferred to adult people because a much more higher number of stem cells.
Okay. So is there a shortage of donors in the African-derived population groups?
Is
Or
much more limited. There are many donors represented this ethnic population.
yeah. So again, that's another that's another.
For an example, a result in American population with sickle cell disease, which is of African origin, has the worse result, much related donor for this population has worse result because of the much higher variability in the genetic characteristic of this population. So the possibility to find a matched donor is much lower than for the Caucasian population.
It's interesting, isn't it? So you've got the science, the base science, you've got the clinical applicability, and then you've also got to be an expert in public relations as well as health economics. Is gene therapy and we're going to dig into this, so it's a bit of a leading question. Is gene therapy a transformative solution for people living with hemoglobinopathies?
Uh, More than transformative, I would say it is a step a step forward in the same direction of the cellular therapy. I think that now it is correct to nominate transplantation and gene therapy as cellular therapy. This is a replacement therapy. So far in hemoglobinopathy, the possibility to be cured was only with hematopoietic transplantation from an HLA identical donor. With gene therapy, any patient can be by a donor of himself. So this is a step forward in the possibility to cure so many patients. And another advantage is that in conditioning regimen, both transplantation and gene therapy require complete myeloablation of the bone marrow. Transplantation require also immunosuppression. Gene therapy doesn't require immunosuppression. This makes procedure safer, even in this case the risk is not zero.
So, will stem cell transplantation remain central in treating thalassemia and sickle cell disease, let's say in 10 years?
Yeah, but this is my opinion, even because the rare and important issue, I think it is cost and price of the product that is not, this is high, very high, and this is probably not affordable for a large part of the patients. And maybe in the future, production issue and the capability of economic situation will improve, and this possibility of gene therapy would be available for a larger number of patients, but I don't think this will be in a short period of time.
Okay. A sort of a sideways question, because of the current treatments or classical treatments, is iron toxicity still under-recognized in clinical care, or is it under-recognized?
Okay, this in the field, this issue iron overload, iron toxicity, and iron chelation has so much improved during the last decade because of the effort of many colleagues involved in clinical research in this field. Now I say that transfusion dependent thalassemia population, at least in the industrialized countries, is very well treated on this point of view. Is the problem is very well recognized and treated. Now we very rarely see patients with a high degree of iron overload, but the problem remain from a patient coming from not industrialized countries, low-income countries. And for this disease, the large majority of patients lives in those countries. So this is a very important health problem, worldwide health problem. Moreover, there's another concept. During the last year, we understood that the problem is not only overload, but is toxicity. Of course, overload means toxicity, but sometimes we can have toxicity even with the low level of overload. This makes a change in our perspective of treatment, and this could afford improvement in the possibility of treat these patients.
Right. Well, it was a bit of a leading question because I'd like to dig in a little bit more. Your work, Emanuele, on iron overload and toxicity has had a major impact on how we manage this issue in the context of both transplantation and long-term transfusion therapy. How has clinical understanding evolved, and where can we improve further?
Okay, so let me introduce the problem. In clinical decision in transplantation and gene therapy, even in everyday medical care of the patient, the problem is not iron overload per se, but the tissue, the damage, the tissue and organ damage caused by iron during the year. To make an example, you can have a patient who had very bad iron control for 7 years and it acquired for maybe 15 years, and as a consequence, a severe liver damage like liver cirrhosis, then he achieved a good control of iron overload in the last 5 years. Cirrhosis and liver damage is there at the same time. It's not improved. So the critical message is what is important is the continuous control of toxicity in the hairs since the beginning of the problem. For example, for gene therapy, for transplant, not only when the transplant or gene therapy is inside, but much before at the beginning of the transfusion dependence. This is the key message. Cannot be a last moment problem, but it must be a problem approaches since the beginning of the transfusion dependence, at least in thalassemia patient and sickle patient. This is the key message.
Okay, so thank you. As chair of the Haemoglobinopathies Working Party at the European Bone and Blood Marrow Transplant,
the group.
Yes, the EBMT, the European Society for Blood and Marrow Transplantation.
Correct.
I hate abbreviations. I always joke.
Me too.
I still give a lecture for new medical students and tell them do not use abbreviations. DOA can mean date of admission or dead on arrival. Using abbreviations assumes something that is wrong. Anyway,
I agree so much with you. I agree absolutely.
Good on you, Emanuele. We're kindred spirits. Thank you for that. I know that in that group you lead efforts to influence research, guidelines, and policy across Europe. What are some of the most exciting or impactful initiatives that are currently underway?
Oh, well, okay. We have several initiatives. First of all, let me say that this is a new working party. This was established in 2023, so we have 2 years. But at the same time, we have more than 10 patients registered in the database. So our first goal now is to improve data quality. After that, we have a unique database set of data to establish the benchmarking for next coming therapy, like gene therapy, like not IgA identical transplantation, and any form of future new treatment. So we have the possibility to have a very important data set showing, demonstrating which is the benchmarking for any future treatment available. This is probably the most important. Then we have several other projects, for example, harmonization of a conditioning regimen, for example, to see new form of transplantation, maybe from non-HLA identical donor. Sorry, HLA is an acronym, but it's human leukocyte antigen, but HLA used now is commonly used. But and moreover, for example, another very important topic is transplantation in adult patients, thalassemia and sickle cell. This is still in an uncovered area, particularly for thalassemia. Our recent data presented by Joseph de la Fuente at the ASH 2004 ASH meeting demonstrated for the first time the in sickle cell disease transplantation in adults has the same result that in children. This is still not true for thalassemia. We have to investigate why, which is the difference, because when we understand the problem, we can propose solutions. So I make a couple of examples, but there are many other topics we are trying to afford. And lastly, very, very important, we started to have a great collaboration with the low-income countries. where the large majority of the patients live today. We have a specific ad hoc subgroup for dedicated to this to these countries, the Mediterranean area, and countries from the Far East area, where, believe me, hundreds of thousands of patients live today.
Yes, if I recall, the haemoglobinopathies are primarily Mediterranean disease.
Mediterranean, but even Far East, far southeast.
I think, there's a truism in medicine, Emanuele, that having had the privilege of working on data initiatives and international collaborations in my field, they are immensely intellectually and emotionally rewarding, and they often lead to very surprising solutions. I remember going to China to operate on a number of occasions and seeing the solutions that they had for dealing with limited resources, which made me question, why do we waste so much money in the West? They do so many things so brilliantly that I think we can learn from each other. That's exciting.
In the field of hemoglobinopathies, particularly in thalassemia, the same data came from India. In India, there are some centers which presented outstanding data with cost much affordable, and this is a field of investigation, of course. And I think that their experience of our colleague can teach us to further improve availability of the procedure for the healthcare system.
Okay. Well, thank you for that. Can you walk us through some of the key recommendations in the most recent clinical guidelines for hemoglobinopathies and how they reflect changes in clinical practice or have learnt from new evidence?
In the field, you mean in the field of transplantation or in the field of medical care?
Clinical guidelines for the hemoglobinopathies, the actual practical guidelines.
Okay, so thalassemia and sickle cell are both hemoglobinopathies, but on the clinical point of view and the therapeutic point of view, they are different, very different. For thalassemia, the problem is transfusion, continuous transfusion, infectious disease, blood-borne infectious disease, and iron overload, iron toxicity. In sickle, in sickle, the problem is the pain crisis of the disease. Okay, in thalassemia, the problem of any patient, any transfusion-dependent thalassemia receives transfusion, so the problem is for any patient. Sickle is much more unpredictable disease, and sometimes it's very difficult to predict exactly the severity of the disease. This is not only the genetic situation, but even involve other aspects. So clinical and social aspect that make this patient more difficult to be treated. So what improvement can be in thalassemia I think that now in the Western country, in the industrialized country, we reach a very high standard of care of this patient. And probably the most important thing is to expand the quality of care to all the patients worldwide. In sickle, really, we have a very few effective medical treatment for patients with the severe disease. In sickle, there is so much we are still to understand on the pathophysiology of the disease. This is the clear point, the difference between these two diseases. And on a worldwide perspective, sickle is probably the most important problem because at least 75 patients of hemoglobinopathy of clinical of hemoglobinopathy are sickle cell disease patients.
Interesting. So thank you for that. We're seeing rapid advances in conditioning regimes, cellular therapies, and you've mentioned gene editing. What are the most promising developments on the horizon for patients with hemoglobinopathies? What's going to happen next year?
First of all, we have two gene therapy approach. One is gene insertion and the other one is gene editing. My personal opinion that today gene editing is the most promising because the lack of the lack of viral vector, because of minor manipulation of the patient of the stem cell genomic, and the most and easily there's absence so far of data for secondary neoplasm, secondary cancer. Of course, much higher number of patients and much longer follow-up is necessary to address these questions. And with a possible further, I think, pretty close improvement is to have less toxic conditioning regimens. So far for gene therapies, it requires a complete myeloablative regimen, and maybe in the close future we can develop a conditioning regimen less toxic and more affordable even by adult patients. In the long term, and nobody knows what is long term. You know that in research you can have an impressive step forward in the next 6 months. You can be close for 10 years and years and years. But what I've seen from many researchers are doing now is to have as in vivo gene therapy. What we have now is ex vivo gene therapy. Ex vivo means you have to harvest the cell from the body, modify in the lab, and then insert again in the body, in this case with the conditioning regimen. In vivo means that the researchers are trying to find a way to directly insert in the human body, in the blood, the correct gene or the gene editing or the viral or the vector for gene insertion, or the CRISPR-Cas9 technique, the possibility to editing the patient stem cell without harvest stem cell before and modify in the lab. But when will be this technique available? We hope, and we don't know why. As you know, research sometimes, often is unpredictable. Result of research are unpredictable.
I would say that's the rule of thumb, Frank. It's unpredictable when it'll be predictable. So, Emanuele, you're very eloquent and you've given wonderful answers to my questions. But what have I not asked you that I should have asked you? That's question number one. And question number two is, can you give, if people remember nothing else from this conversation, one thing that they should take away with them? Two questions.
I think that the major message is cellular therapy is impressive progression in possibility of medical care for patient in the last year, with a continuous improvement, with a very strong academic effort worldwide, and it promise further improvement in the next coming years. The second message is to expand this possibility of treatment to people who cannot afford this possibility because of economic problem, and these patients are so many in the world. A question, it's not easy to answer. What would be what can be a missing answer, a missing question? A missing question can be when do you think that there is a competition in the academic world and the industry world between transplantation and medical care, my answer would be yes, it has been, but should not be, because both techniques are dedicated to improve patient care. And in thalassemia, in malignancy, and even in hemoglobinopathy, the very important and most important key of success of transplantation is not only transplantation per se, transplantation technique, but the condition, the clinical condition of the patient when they arrive to transplantation. If they are being well treated before, the possibility to have a successful transplant is very high. If they have been bad treated, they have been treated in another good way before, the prognosis with transplant is much worse. This is the commitment. Both technology, medical care and transplantation, and physician for taking care of using medical therapy, and physician using transplantation are fighting the same fight against the disease, and the collaboration between them is the key of success.
Okay, thank you very much for that. Well, Emanuele, we always like to close these podcasts with a question. If a genie granted you 3 wishes to improve the care of the patients you look after, what would you wish for? You have 3 wishes.
This is good. Okay, you mean for any patient, malignancy, hemoglobinopathies?
They're your wishes, my dear chap. You can wish for what you will.
Okay, of course, we are wishes are an optimistic way to look at the future, but we live and we operate in the real world, and we know that in the real world there are problems. My first wish is to better understand the disease. Second, to following and better understanding the disease, to develop treatment for large parts of the disease. And finally, and I repeat what's already said, to make treatment possibility to a larger number of patients as possible.
Well, it's been an absolute delight chatting to you. And you're very gracious. You only choose one thing. So, Professor Emanuele Angelucci, thank you so much for spending time with us. I know that you do a lot of work with EMJ in editing their journal, and I know you do a lot of work looking after these patients. So, from the bottom of my heart, thank you, sir. Well, I hope you enjoyed that episode of Hema Now, our bi-weekly podcast on hematology. Please consider subscribing on either Apple Podcasts or Spotify, or frankly, wherever you get your podcasts, so that you never miss an episode. Like us on social media, tell your friends and colleagues, and please check out the archives because they're growing if you've missed any episodes. And please join us again in 2 weeks for another episode. Until then, I'm Dr. Jonathan Sackier. I'm proud to be your host. Please, everyone, stay safe, stay well, stay curious. Bye for now.